like to invite Dr. Jenny Aldrink and Dr. Sarah Mansfield to the stage for the COG update on several clinical trials.
Good morning. So today we're going to spend the next 30 minutes discussing a couple of updates from the Children's Oncology Group. I have the privilege of updating the group on AREN2231, which is a risk-adapted treatment of unilateral favorable histology Wilms tumor. As many of you in this room know, there has been a drought for clinical trials for patients with Wilms tumor for several years. This clinical trial opened on March 28th. And so encourage your oncologists to work on getting this through your IRB and opening it at your centers. And this is an all-inclusive clinical trial for all stages of patients with unilateral Wilms tumor. What I'd like to do in the next 20 minutes is just go through some of the high points, particularly as they relate to the surgical aims. All right, so renal tumors in the past have all enrolled on AREN03B2. This was an all-encompassing biology and banking study through which children were enrolled and then underwent central review. That trial has now closed and been replaced with APEC-14B1, or something called Project Every Child. Project Every Child encompasses all tumor types, not just renal tumors, but the renal PEC is the biology banking replacement of O3B2. The important things to remember are any patient with a suspected on imaging renal mass can be enrolled in this. You don't need pathology to confirm. So as soon as you have an imaging that shows a renal tumor or suggests a renal tumor, start sending that information in to your clinical research team, and they will send this through APEC-14B1. This then will allow rapid central review in the situation of a favorable histology Wilms tumor or eventually bilateral Wilms tumor, some of the other histologies. But 14B1 or renal PEC you'll hear has replaced O3B2 as the encompassing biology study. Once the child has enrolled on APEC, 14B1 or renal PEC, this will then outflow through several of the clinical trials. Currently, we have AREN1921, which is the diffuse anaplastic and relapsed favorable histology Wilms tumor, and that study that is open, and then AREN2231, which just opened. Eventually to come, through the rhabdoid working tumor group and bilateral working group, will be new clinical trials on those diseases. Today, I just wanted to focus on some of the key points of 2231. As I said, as soon as a renal mass is identified, start sending imaging in for central review. The other key point is the child will not be eligible to enroll on a therapeutic clinical trial without a histologically confirmed lymph node. We all know that lymph nodes have been encouraged. Now they will be mandated, or the child will not be able to enroll on these studies. Right now, this includes 2231 and 1921, but it will be an overarching aim for the future therapeutic trials. The first group I want to discuss is something called a modified very low risk group. This is a newly expanded and refined group from prior 05 series studies that included nephrectomy-only patients. If you recall, patients who were 2 years or under with very small tumors could be observed in appropriate clinical settings. This has now been expanded to age 4 years or under 4 years, any tumor size with negative biomarkers. The biomarkers are listed here: LOH1P16Q, 11P15, and 1Q gain. And so in the absence of those, any stage 1 patients under age 4 has the potential to be observed. Furthermore, stage 1 epithelial predominant tumors of any age can also be observed, maintaining excellent survival. I won't go through all this data, but I just wanted to put this slide up here that was developed by Elizabeth Mullen and her team with the Renal Tumor Committee, just showing that there has been a lot of research, many of whom are in this room and contributed to this, that goes into the rationale for expanding this very low risk group. Here is the schema for stage 1. I don't expect you to read through it. This is in the actual protocol, but these two arms or flows are where these patients will live who undergo who have standard biology and undergo nephrectomy only. Surgical considerations for this group are several. So unilateral renal tumors, they cannot have any confirmed or suspected predisposition syndrome. They cannot have a solitary kidney. They have to undergo upfront nephrectomy without intraoperative spill, which would upstage them. Partial nephrectomy patients are not eligible for the modified very low risk group on this trial. They absolutely have to have lymph node sampling or they will not be able to enroll on 2231 and won't be eligible for nephrectomy only. Lymph node sampling within an appropriate nodal drainage system is also required and has to be confirmed pathologically. I put this diagram in. This is in the surgical guidelines section of the protocol that you can reference, showing where these lymph nodes should be harvested and documented in the operative note. I will end the talk in a little bit on discussing the Synoptic operative report for renal tumors and show you how that can be documented. But this is where we want the lymph nodes sampled. We do not encourage or require an RPLND, but we don't want mesenteric lymph nodes either. So within the appropriate drainage system of the kidney. The other very important thing to consider is central venous access timing. So this very low risk group is expanding. Approximately 10 to 15% more patients will be eligible to avoid chemotherapy, and so we have to be thoughtful about when central lines are placed. These are some general guidelines. For children less than age 4 without obvious metastatic disease, we recommend waiting the final stratum assignment, that is, waiting for the biomarkers to return before placing central venous access. On occasion, using frozen section for lymph nodes that you are suspicious of can be helpful after the lymph nodes are removed. That may give you some information that this patient would be a higher stage than you suspect, and you can proceed with central venous access at the time of nephrectomy. Considering placing central venous access for those who are over 4, although as you recall from the schema, there are patients with epithelial predominant tumors that would still be eligible for nephrectomy only. So it is going to take some thought. The final risk assignment should be returned by about 21 days. That's all the biomarkers. This procedure for central venous access could potentially then be combined with an oncofertility procedure if that was desired. So quickly moving through stage 1 and 2 patients who are not eligible for the very low risk or nephrectomy only arm. So those with either over age 4 or with any negative biomarker will be treated as before with EE4A. Stage 2 patients who have negative biomarkers will be treated with a novel or randomized to a novel regimen of something called VIVA, which is EE4A plus a VI window. Standard biology will continue to receive EE4A. For stage 3 patients, those with standard biology, the aim is listed here. We encourage upfront nephrectomy whenever possible. We haven't changed or recommended anything different than the indications for delayed nephrectomy that have been in place for many years. So upfront nephrectomy is encouraged whenever it's feasible, as long as they don't meet any criteria for delayed nephrectomy. The important thing for stage 3 patients is that for those with standard biology, some will have reduced treatment, meaning they will be de-intensified from DD4A to EE4A, so doxorubicin will be eliminated for some in the absence of negative biomarkers. In addition, some patients will be able to avoid radiation therapy. So this is going to be an important process for these patients and also looking for late effects. And you can see here patients who undergo upfront nephrectomy with standard biology will receive EE4A. Those with adverse biology will be randomized to regimen M versus MVI. The difference is that MVI has a decreased cyclophosphamide dose that is less gonatotoxic, and this is where they fall. Relevant surgical aims for stage 3 patients with favorable histology Wilms are to describe the impact of the number of anatomically relevant lymph nodes, 1, 2 to 4, or greater than 5, on survival, to determine the effect of lymph node density, or the number of involved nodes versus the total number of nodes harvested, on survival, to document for those who are not eligible, in the surgeon's opinion, for an upfront nephrectomy, to document the type of biopsy and how this, what the rationale for performing the biopsy is, and to describe the treatment and outcomes and morbidity related to resection of patients who have IVC tumor, specifically looking at surgical approach, radiation therapy, et cetera. For stage 4 patients, those who have standard biology, pulmonary-only metastases will be treated similar to 0534. As you recall, those who have a rapid complete response and complete resolution of their pulmonary nodules can avoid pulmonary radiation potentially. And then those who have adverse biology will again be randomized to regimen MVI versus regimen M. Here is the schema for stage 4 pulmonary only rapid complete responders versus those who are slow incomplete responders or have adverse biology. Some of the relevant stage 4 surgical aims are related to pulmonary metastases. So one of the aims in the study is to potentially increase the number of patients eligible to avoid pulmonary radiation by encouraging resection of 1 to 3 residual nodules after 2 cycles of chemotherapy. And then also to describe whether residual nodules at the end of therapy are associated with relapse. So what does this mean for surgeons? Well, consideration for pulmonary biopsy may occur at 3 specific time points. Number 1, at diagnosis, if the nodules are indeterminate and the decision is unclear whether to call them stage 4 or go by local stage. Number 2, after 2 cycles of chemotherapy, if 1 to 3 nodules remain and in your judgment you feel these can be completely resected, and if pathologically they are either completely necrotic or not tumor, then these patients can avoid pulmonary radiation with the associated morbidity. There's no description or requirement for approach, so in your judgment, either minimally invasive or open at your discretion. But we don't recommend 15 to 20 nodules being resected, but 1 to 3. And then number 3, if at any time point the nodules increase in size or number and there's concern about the pathology. So again, the timing will be important, particularly at the 6-week period or after 2 cycles. And so if you have a patient that's stage 4, potentially eligible for this, just reserve time on the OR if you think that this might be somebody that you can resect 1 to 3 nodules and could potentially spare them radiation. Extrapulmonary metastases and surgical aims. So one of the aims is to describe recurrence for liver metastases, and depending on the method of treatment or local control, we do not recommend resection of extrapulmonary metastases or liver masses at the time of nephrectomy, but rather that we see how these respond to treatment and then surgically controlled or with radiation. So I'm going to transition to a couple slides on the Synoptic Operative report. This is the current Children's Oncology Group renal tumor surgical roster, many of whom are in this room and have done amazing work on prior studies in this current study. So I just thank everybody for their service and their work on this. I'm privileged to be able to be part of that group. So for those of you who are Epic users at your institution, this is important. Many of the tumors are developing Synoptic operative reports that will assist us in being able to capture data directly related to the clinical trials. Neuroblastoma is almost open. I know there's a sarcoma and other ones in development. The renal tumor is operative report is in Epic. With the February upgrade, I'll put something on the end of that. I'm Ken Gao, Andy Davidoff, Nick Costin. I worked with the Epic team to design this, incorporating many of our surgical aims into this note. It's called .SOR Renal, and that will be a theme with other operative reports too as they become developed. So the structure of the Synoptic operative report is pretty simple. The laterality, procedure details, whether or not venous access was placed, and blood loss and complications. So for example, and I'm not gonna go through all of these, but I just kind of wanted to show you, some of the specifics of the incision used, the intraoperative decision-making, lymph nodes harvested, blood loss and things like that. So, and then same for a renal biopsy, if that is performed, there is an algorithm within the note that will pop up based on what you've selected. It's very user-friendly, was venous access placed, volume loss, and then intraoperative complications. And so the Synoptic operative report final forms will look like this. This does not replace the dictated, detailed operative note. Most institutions require that still. But this is a way to be able to capture a lot of the data that we want for the surgical aims directly into the note. So the records, again, .SOR renal. If you are an Epic user, you can ask for this turbocharger package currently, and the note can be potentially brought in. It is also behind the scenes, and all that data that will be collected will come with the February 2025 version. Most institutions are 6 months, 8 months behind the upgrade, but it will be coming. So you just find your Epic specialist and ask for this to be brought in with the next upgrade. We would encourage you, if you're an Epic user, to not create your own note, but to wait till this upgrade happens. So with that, I will end. I know there will be many questions, but I wanted to save time for Dr. Mansfield and her presentation. My email is here. Ken Gao, who has done amazing work with the Synoptic operative reports, email is here. And Nick Cost, who is our current chair of the Renal Tumor Committee, his email is on as well. So thank you for your attention, and I'll turn it over to Dr. Mansfield.
All right, thank you so much. I'm going to briefly go over the recently opened neuroblastoma trial 2131. So the overarching aim of this trial is to evaluate the efficacy of immunotherapy given during induction. So despite a lot of progress with the treatment of high-risk neuroblastoma, it's still challenging, and a substantial number of high-risk patients will have disease progression during induction therapy. Immunotherapy in the form of anti-GD2 antibody or dinutuximab has been efficacious in a variety of roles. So on ANBL2131, it was added to the post-consolidation regimen and improved event-free survival from 60 to 66 from 46 when compared to retinoic acid alone. And then in 1221, dinutuximab was used compared to irinotecan and temozolomide for relapse or recurrent disease, which importantly had a higher disease burden than the minimum residual disease during consolidation. And again, showed pretty dramatic response rates. We also gained some pharmacokinetic information from that trial, knowing that the best response was seen after the between cycles 2 and 4 of dinutuximab. So this ultimately led to a pilot study single institution study out of St. Jude, where they used an anti-GD2 antibody during induction and improved the observed response rate to 68 from 39%, and importantly, no patients in this trial had disease progression. There was also some hints that this may improve survival as well when they looked at the event-free and 3-year overall survival compared to our historic cohort on 0532. There was about a 20% improvement for both of those. So this led to the current study, which is now open, ANBL2131. So patients with high-risk neuroblastoma will all undergo the same cycle 1 of topotecan and cyclophosphamide. That cycle 1 will allow time for the BPC to test those samples thoroughly and give us information in order to randomize patients. So once they are randomized, Arm A includes just standard induction therapy as has been done on previous trials. Arm B has that same induction therapy, but with the addition of dinutuximab, as well as an immunostimulant with GM-CSF. Surgery should take place at the same point for each arm, which has been done on the previous trials after cycle 4. If patients have disease progression, there is a breakout point where they can undergo extended induction. Additionally, if they're not having a good response to their induction therapy, they also branch out into this other arm. This trial will introduce some terminology that we haven't seen before, a GEAR and a PEER, so a good end of induction response or a poor end of induction response. Both of those generally follow the INRC response descriptions that have been used previously, but also include some metastatic disease response. These are really important endpoints for the study, so they will undergo central review, so I won't belabor all of the details for that. But generally, if patients get to the end of induction and haven't achieved a GEAR, they will then enter this extended induction, where if they haven't had dinutuximab before, they could potentially get it here. The post-consolidation management is the same: tandem stem cell transplant, radiation, and then the post-consolidation therapy. So as I mentioned, this is for high-risk neuroblastoma patients. I won't go through all the details here, but I did want to point out that the risk classification system has undergone some slight modifications just in the last few years. So if you have not read the Irwin et al. Paper in JCO from 2021, it very nicely summarizes those subtle differences and how segmental chromosomal aberrations have impacted the classification scheme. So as I mentioned, the primary aim is event-free survival in patients with high-risk neuroblastoma treated with dinutuximab during induction versus standard therapy. There are many exploratory aims on this study, but just a couple of surgical interest. One is to describe the adequacy of the biopsy specimens and compare them based on the route for which they were obtained. And then we also want to understand how image-defined risk factors change with induction therapy and how those remaining IDRFs at the time of surgery impact completeness of resection, surgical outcomes, complication, local failure rates. So you may have heard a little bit on the renal side, the timing is everything. So the biopsies need to be sent for central review very quickly. So they need to be adequate so that we don't have to go back and get additional specimens. They need to be adequate because they have to get a lot of information from them in order to get randomized, including the histopath, MICN amplification, segmental chromosomal aberrations, and ALK status. So you need a minimum of a cubic centimeter of viable tissue, or almost 30 cores, large cores, again, of viable tissue. Any biopsy route is allowed on the protocol, image-guided or surgical biopsies. If you are going to be performing a surgical biopsy, highly recommended to carefully review the imaging so that you are targeting non-necrotic tumor for the biopsy. And then additionally, having a pathologist review in real time is also important to make sure you're getting viable tissue. These need to get out the door as quickly as possible. It takes about 18 days for the BPC to do all of the analysis, and these need to be randomized before it's time for cycle 2, which is about 22 days. Other surgical key points. So as I mentioned, surgery should happen after cycle 4. If the patient is sick or just not able to undergo surgery at that point, after cycle 5 is allowable, but surgery does need to happen. The only exception would be if the tumor responds, which if that's the case, great job. They go on to the consolidation therapy. The resection goal is not a %, but, quote, the most complete tumor resection possible with preservation of organ and neurologic function while avoiding complications. So the avoiding complications piece is important as chemotherapy really needs to resume within a week from surgery. An upfront resection may be performed for small, potentially L1 tumors that are high risk due to metastatic disease, but only if it is, quote, a chip shot and low risk, as we do not want any delays to their chemotherapy. Minimally invasive techniques are also allowed at the surgeon's discretion with the same oncologic goals and principles. Please send the tumor fresh, as there are biology correlatives on the resection specimen. And then just to say it one more time, every attempt should be made to preserve organ function, specifically the kidney. So this study has been open. It opened April of last year. The accrual as of this morning was 133, I believe. So it's meeting all of its accrual targets and has been cranking along fairly well so far. I'm not sure if we have time for questions, but I do have a list of email addresses, and everyone on this list is more than happy to answer any questions that come up, or you can come find any of us later today and be happy to help. All right, so I think we are ready to move on. Oh, thank you so much.